Good afternoon, everyone. Thank you so much for joining us today for our webinar. Dr. Ketchum, we're ready to get started. Thank you.
Okie dokie. All right, everybody. As you may know me, I'm Eric Ketchum, an emergency physician from New Mexico, also the current chair of the ACEP Pain Management Addiction Medicine section. I'm going to share my screen here real quick. And I'm going to introduce Jeff Davis. Jeff Davis is from our DC office. He is our Director of Regulatory Affairs. So what that means is that Jeff Davis has been awesome, and our whole DC office has been awesome pursuing changes to the XWaiver, to Data 2000, and a variety of other things to really improve access to addiction treatment, and particularly improving access to addiction treatment in the emergency department. So, Jeff, do you want to just say a few words?
Yes, thank you, Dr. Ketchum. We're very, very excited to be able to present this to you today. As you all know, the original topic of the webinar was just to discuss the Easy MAT Act, but we have never, Dr. Ketchum and I have never been so excited to change topics so quickly and discuss the new practice guidelines that HHS put out to effectively eliminate the XWaiver. So again, it's a pleasure to be here today. We're happy to answer any questions. And as we're note, we're also waiting for some clarifications from HHS as we go along with some issues. So this is not the last opportunity you will have to engage with us on these important new guidance and new practice guidelines. And we're going to be continuing engaging with HHS on some of these issues. So thanks so much for being here, and I'll turn it back to Dr. Ketchum to get started.
All righty, so we're going to talk about the background on the XWaiver requirement a little bit. A little bit on the new practice guidelines and overview, and we're going to talk about the 3-day rule and the Easy MAT Act. A little summary, refer you to some resources, and then we got plenty of time for some questions. So just to give you a little history, right? So the XWaiver all started with what's known as the Drug Addiction and Treatment Act of 2000, when this was passed by the US Congress. It went into effect in 2002 after it worked its way through the regulatory process, which is the process that new laws have to work through to actually get implemented. And with this came the requirement that you had to get a DEA XWaiver in order to prescribe buprenorphine. When I say prescribe, meaning to either discharge somebody to the hospital from the hospital with some, or to give them a prescription they can take and fill at a pharmacy. There was, of course, the exclusion if you just wanted to administer it in the hospital. That did not require the XWaiver. And to get the XWaiver, of course, you had to complete this 8-hour training course. Then you had to apply for the waiver from the DEA through SAMHSA. Then you had to wait somewhere between 30 to 90 days or longer to finally receive that XWaiver, in the mail, or receive that notification online that was done. In 2017, CARA went into effect. This was passed in 2016, but this enabled NPs and PAs to obtain XWaivers. But they, however, now required to get 24 hours of training, so 8 hours live and another 16 hours online. So this, by the way, CARA was the Comprehensive Addiction and Reconciliation Act, Rehabilitation Act. So ACEP has long advocated for removing the XWaiver requirement, and we've been particularly vocal about this in the last 2 years with a lot of meetings on the Hill, partnering with a lot of other stakeholders in the field of addiction treatment. I think we can all recognize that the XWaiver is just an unnecessary barrier to treatment, and many of us feel that it just contributes, in fact, to the stigma of opioid use disorder. So these are basically the new practice guidelines. January 14th, Department of Health and Human Services issued a practice guideline, an exception that essentially eliminates the XWaiver requirement to prescribe buprenorphine for physicians, particularly emergency physicians, hospital-based physicians. So there are a couple explanations of the exceptions, which we're going to go through in a little detail. And this goes live whenever the practice guidelines, these new changes, this exception is registered in the Federal Registry. Can you explain that a little bit more for us, Jeff?
Yeah, sure. So the Federal Register is the official, place where all regulations are kept. It takes a few days. It's a slow process to get it officially placed in the Federal Register. We have reached out to HHS. This is one of the issues we reached out to HHS on and say when exactly will be placed in the Federal Register, and they say, quote unquote, in the next couple of days. So we'll keep an eye out for that. But we confirm that once they are placed in the Federal Register, these new practice guidelines and this exception that we're discussing today, it becomes effectively immediately thereafter. So we'll definitely let you know once it's officially placed in the Federal Register.
So Jeff, on that note as well, this happened in the last week of the Trump administration, which I don't think really had much to do with the Trump administration per se. But because of that, is there any concern that once now that we have a new administration coming in, that this will get delayed further, or that this decision, will be reversed? Are you all concerned about that at all?
That's a good question, because, I think they're doing a moratorium on new regulations. I certainly hope not. This has certain bipartisan support. This is pretty well accepted across both parties, and it was a big priority for the incoming administration as well, to remove the X-Waiver. So I certainly hope that it would not get delayed in any way. Of course, you never know until it's actually in the Federal Register. So we're keeping a close eye on it. But yes, we're carefully monitoring that. But again, as we discussed a little bit later, this is not a new law that was placed that creates this exemption. It's through a practice guideline, which means, as we'll discuss a little later, that has to be reviewed by the incoming administration and maybe updated or revised over time. So that's something else we're going to continue to monitor as well.
All right, well, we'll get back to that. So this is the details. First of all, this exemption applies only to physicians. NPs, PAs, they still have to obtain an X-Waiver to prescribe buprenorphine for opioid use disorder. There's no change to anything involving methadone. That still can only be used to treat opioid use disorder in a specialized clinic or while the patient's in the hospital. You can only prescribe it for pain if you want to prescribe it to be filled at a pharmacy. If you're using this exemption, in other words, if you don't use an X-Waiver to prescribe buprenorphine, physicians can only prescribe buprenorphine to be filled at pharmacies where that physician has a state license. So that is I think an important small caveat, right? Because there are some prescriptions, that you can call into a pharmacy in another state where you don't have a license, but buprenorphine would require that you have a license in that state. Okay, this is a kind of a vague wording right now, which we're hoping to get some clarification on. They still want you somewhere to write an X. Now remember, the X currently replaces the first letter of your DEA license. That's what the X-Waiver is. It gives you a second DEA license where the first letter replaced by an X. So we don't know exactly what this is going to look like. But in the meantime, while we're waiting for some further clarification, we're just suggesting this, like in the SIG line or right after the SIG line, that you just put a simple quote, capital X, for opioid use disorder. In your electronic prescribing, like I use in Epic, there's a note to pharmacy section. That's another place you could potentially enter this. But we don't have a definitive ruling. It's kind of a strange statement. But the implication is if you put an X on it, it means for opioid use disorder. So there's also no limits anymore. So at least for hospital-based physicians, right? So your EM docs, your hospitalists, people working in the hospital prescribing. There used to be a 30 patient limit, which you'd have in the first year of your X-Waiver. Not that really ever impacted emergency physicians who were only working in the ED, only prescribing buprenorphine in the ED. But ACEP still appreciates the exemption for EM physicians from HHS. I think even though this doesn't really affect us now, it does show, I think, another sign of maybe the crack in the wall. That hopefully this exemption, could then be applied to other physicians. But it does remove one small headache from emergency physicians who might be really active, no longer having to kind of follow a log in that way. So you can obtain an X-Waiver if you want, or if you already have one, continue to use it. This would be relevant if you're using your X-Waiver typically outside of the emergency department. If you do like I do, you do inpatient addiction medicine consultation, or if you have a clinic, and then you do have to keep track of how many patients you have. So if you get your X-Waiver, of course, you'd still be subjected to the current limits, 30 active patients at a time in the first year, 100 in your second year. And that's assuming that you didn't apply for it and get one of those COVID-19 exceptions that have more than the stated limit, et cetera. If you want to work in a clinic, Without an XWaiver, it just means that you're going to be subjected to the 30 active concurrent patient limits, right? So what that means, of course, is you can have 30 patients at a time who have an active prescription from you. So by active, I mean, it's like if you're looking at your PDMP report and your PDMP, says this script was filled on this date, like January 20th, 2021 for 30 days, that means that prescription's active, for 30 days. So if you don't get an XWaiver, you want to work in a clinic, then you still will have to, be subjected to that limit. You'd have to get an XWaiver to be able to exceed that limit. So there's also a statement about separate records, that you have to keep separate records, which I think creates a little bit of confusion. So what this refers to is that if you have patients who are being treated specifically for opioid use disorder, then therefore that would subject you to the regulation known as 42 CFR Part 2. And this is essentially a higher level of privacy standard, but we don't expect this to apply to the emergency department. It doesn't currently apply to the emergency department. The emergency department is a specific written exemption to 42 CFR. So this really applies to clinic visits, particularly clinic visits that are dedicated to treating substance use disorders or inpatient addiction medicine consultation notes, like I might write. Those have a higher level of privacy standard. So I think this really is a statement that reaffirms the existing requirements. So anything that would currently be subjected to 42 CFR Part 2 would still be, subjected to 42 CFR Part 2. Jeff, is that the interpretation you all have so far?
Yes, I think the pertinent words here are the words that are italicized in the slide, pursuant to Title 42 Part 2. When they use the term pursuant to, that means that it's just reaffirming current rules. So whatever you do currently, as Dr. Ketchum mentioned, there's an exemption for emergency care. So a lot of the care you provide may be already exempted from 42 CFR Part 2 requirements. Or if you do provide care and you are well aware of the requirements, nothing's changing. It's just reaffirming current requirements. Yeah, and the pertinent words here again are pursuant to Title 42 Part 2. They aren't adding any additional requirements than are already there to this.
All right, Jeff, thank you. Outstanding. All right, so here we have a couple caveats, right? In fact, Jeff, I'm gonna let you run through these. So
sure. So just to reiterate, this is very important, and Dr. Ketchum mentioned this. The exemption only applies to physicians, does not apply to non-physician practitioners. So the XWaiver is still required for NPs and PAs. And then this is very important, and I mentioned this a little earlier in the presentation. We have been pushing for legislation, actually, that will make a clean fix to the XWaiver and to eliminate the XWaiver. This is not an actual elimination of the XWaiver requirement. What HHS is doing in this case is issuing an exemption through practice guidelines, which they have the authority to do, to effectively create an exemption for certain individuals, in this case physicians, and then also not having a limitation, but patient limitation for emergency physicians. But again, it is not a clean-cut elimination of the XWaiver. So it's because of that, the guidelines have to be reviewed and maybe updated by the incoming administration, now the current administration, and therefore are subject to change. And actually in the practice guidelines, what they say is that they'll be setting up an internal working group to monitor the implementation and result to these practice guidelines, as well as the impact on diversion. And they have to make recommendations to HHS on whether the guidelines should be continued, discontinued, or modified. There's also another statement in the practice guidelines talking about education, saying that colleges of medicine are strongly encouraged to continue implementing comprehensive training in substance use disorder diagnosis and management as a component of their core required curriculum. So again, education, and again, there's going to be a working group set up by HHS to really evaluate these guidelines, and they could change over time. And that is why, as we discussed later on, we're going to continue to pursue a clean fix and legislation that will continue to remove the XWaiver requirement. So I think you can go on to the next.
Yeah, so on that note, last year, or actually the year before, in 2019, the MAT Act, was introduced. Not the Easy MAT Act, we'll talk about in a minute, but the MAT Act, which was bipartisan legislation, House resolution, it was 2482. So in the new Congress, of course, this would require, it'll be a new bill with a new number. it'll probably look something similar, I'm assuming. There was companion resolution introduced in the Senate, also called the MAT Act. It had a different little addition to it, but also bipartisan legislation. Jeff, would you expect that we should see another similar thing introduced again to kind of make these changes permanent, to expand them?
I would think so. I would check with our team here on that, but I would think that they would be introduced again. But again, at this point in time where we are, I don't want to sell short what's happened with these practice guidelines. ACEP is very, very happy that these practice guidelines were introduced. So we're seeing
yeah, I agree.
What the station will be. Sorry?
Yeah, I agree. This is absolutely
this is really big.
Enormous step forward. And even if this remains an exception for a long time, this really does a big game changer for us in emergency medicine. This is wonderful for our patients. It's really going to improve access to care. So we talk about some implications. You got to consider what steps do you or physicians in your hospitals need to take to understand, to operationalize, this policy change. We recommend, working obviously on your ED/EMR. We're already having these discussions in our hospital system to figure out, and we're a multi-hospital system on Epic. And so, we have to figure out how do we make this change for the emergency department without necessarily changing the standard scripts in our clinics. So there's a little bit we'll have to sort out. And also for how does this work if an MP is writing the script. So I'm sure you'll all have these discussions to how do you make this operational and kind of, efficient in your hospital system. And just remember, of course, just like in the past, if you write that this is buprenorphine for pain, then it doesn't count. You don't need to put an X on it. It doesn't apply. We're going to wait for some further guidance about separating the OUD charts, but like I said, we doubt there's going to be any change for the ED, just as Jeff explained so well. Educational programs, we hope that you'll continue to do that to encourage adoption of buprenorphine prescribing by your non-waivered EM docs, those who are not prescribing currently. Hopefully you can use this to further encourage them to take up the practice. And of course, you'll need to find a way to continue to encourage your PAs, your MPs to obtain those X-Waivers. So this is also exciting. Within our pain management addiction medicine section, we work closely with our ACEP administrative folks out of Dallas in particular, with Sam, partnering with the American Academy of Addiction Psychiatry. And we were able to produce this 8-hour emergency medicine focused X-Waiver course. And then of course, we turned that into a 4x4 version, meaning 4 hours online, as well as 4 hours in a live class. Of course, our live class, of course, are all Zoom classes. By the time we actually went live with this, we've had great feedback on the quality of the course by emergency physicians, but also by other specialists who've chosen to take our version, including psychiatrists, hospitalists, OB/GYN docs, docs in critical care. So we've had really great feedback on that. But what we want to do is we're going to be assembling soon, really in the next week or two, to start a new plan for how we can make like a 1 to 2 hour bare bones key essential session to really give all emergency physicians the key information they need to start working with buprenorphine right away without having to wait for an X-Waiver. We don't know exactly what that's going to look like, but it's going to be quality education. It's going to be high yield education. We may also add in some short modules on additional advanced topics, maybe some more kind of case reviews, something we've had great feedback on. So more to come on that, and we hope to have that all rolled out within the next month or two. So more to come. Okay, we're going to talk about the change to the 3-day rule. This is the Easy MAT Act, and I'm going to have Jeff kind of walk through this basically adjustment, kind of the current rule.
Sure. So the 3-day rule was an exception, or is an exception to the X-Waiver requirements. So it's a long-standing exception to the X-Waiver requirements. So the existing exception only applies to physicians, actually, the existing one, and it allows non-waivered physicians to administer but not prescribe or dispense buprenorphine to persons for the purposes of relieving acute withdrawal symptoms when necessary, while arrangements are being made for referral for treatment. So why is it called a 3-day waiver? Where it says that not more than 1 day's medication may be administered to the person for the use of the person at one time. So again, Such emergency treatment may be carried out for not more than 3 days and may not be renewed or extended. Now look at the bold words here. 1 day, 1 day's medication at one time over a 3-day period. So what does this mean logistically? It means that in an ED setting, it creates a significant barrier. Patients need to come back to the ED each day over a 3-day period to receive their treatment. They can only receive 1 day's worth. You see that in bold, 1 day's worth of medication at one time over a 3-day period. And it may be very difficult to come back to the ED every day over a 3-day period. There may be transportation issues, long waits at the ED. You may not be able to miss work multiple days in a row to go to the ED. So it significantly impacts the ability and effectiveness of initiating people in the ED without an X-Waiver, despite the intention of the 3-day rule. And again, the intention is good. The intention is to allow for physicians to be able to administer buprenorphine in emergency cases to patients without an X-Waiver. So it's really a good intention, but actually, unfortunately, a little bit flawed. And next slide, please.
Yeah, and so just to add to
And
that,
go ahead.
yeah, we all know that this was well intended, right? The idea was that if you have a 3-day rule, that if your patient comes in on a Friday, this is how they came up with 3 days, by the way. The patient comes to the ED on Friday or to a clinic on Friday. You don't have the ability to get them into a prescriber, as if there were suddenly going to be prescribers everywhere, right? And so therefore, your patient could come back, up to 3 days in a row into the emergency department, receive that dose, and then the next day, of course, they would magically be in front of, a prescriber who would then continue their care. That was the idea when they wrote the thing. But just as Jeff outlined, we know that from clinical experience that this has only worked for a few patients. But there's all these barriers have made this overall impractical and relatively unsuccessful in most environments.
So we've actually been working with Representative Rule Ruiz from California, who's also an emergency physician, on the Easy MAT Act, which attempts to address this issue. We were very happy that the Easy MAT Act was actually incorporated into our short-term funding bill on December 11th of last year. So what it does, it requires the Attorney General, who will delegate this to the Drug Enforcement Administration, or the DEA, to revise the 3-day rule within 6 months, so 180 days, so that practitioners, and look at the word practitioners, not just physicians, but all practitioners, in accordance with applicable state, federal, or local laws, are allowed to dispense is another word we'll talk about in a minute, not more than a 3-day supply of buprenorphine to one person's use. So overall what that means is that you can dispense up to 3 days worth of medication to that patient at one time instead of having them come back to the emergency department. So this is talk about giving a little bit of an example. So patients can presumably receive 1 day's worth of medication while at the ED and take the remaining supply medication home. Again, saving them from having to make multiple trips to the ED. Now, one thing, again, we'll talk about the regulatory process in a minute, but the DEA has to flesh this out in regulations. So some of the definitions and the wording does matter. But one thing that we do know from the law is that by using the word practitioners, NPs and PAs will be allowed to dispense 3 days worth of medication at one time. As I mentioned earlier, the 3-day rule originally was just restricted to physicians, but now NPs and PAs will be allowed to dispense 3 days worth of medication at one time. But it does talk about state and local and federal laws. So state scope of practice laws are in place. So it may be different in different states, but what the ability of PAs and NPs and other non-physician practitioners will be able to do in terms of these medications. Anything you want to add, Dr. Ketchum?
Yeah, I think one of the challenges here also was just that word dispense, as we've learned, which it sounds like, I know in all the discussions, the back and forth with the Congressional Budget Office, the DEA, et cetera, the DEA preferred this word dispense, but we know this can create some challenges for some states where it specifically say that a hospital cannot dispense medication, and that was written to make sure that hospitals didn't set up their own pharmacies, competing with retail pharmacies, et cetera. So I believe that ACEP is going to be working very closely with DEA and following this to kind of see what you can do to kind of, I guess, refine that language or add further clarification of what the intention was. Could you explain that a little more?
Sure. So yes. So again, the DEA has 6 months to issue a regulation to make this actually regulatory change, to change the 3-day rule from where it stood before to the new change that that Easy MAT Act provided. So 6 months from December 11th, when the law was passed, is June of 2021. So that's when we expect the regulation to come in. But like any regulation, we can comment on it. We can ask for clarifications. We can try to meet with the DEA throughout the regulatory process to get clarification on some of these issues. And again, one of the issues that Dr. Ketchum mentioned was the word dispense. Trying to get clarification, meaning, what do you mean by dispense? Does that mean including administration of the medication widely ED, or just dispense, meaning then you could just take home 3 days worth of medication? What exactly does that mean? And fleshing that out a little bit, and making sure that the pharmacies really understand the definition too, that it's clear enough that hospital administrators, pharmacies, and other stakeholders really understand what the requirements are and how and what changes they need to make in their systems to be able to allow for this to occur.
So I think on that
But
note,
also mean,
if I could,
go ahead.
you know, in the discussions that had directly with the Congressional Budget Office, when we were writing up, you know, what this all meant, and as you all were working with, you know, the different legislators, you know, our congressmen, et cetera, on the Hill, everybody understood the purpose, that this was all about being able to provide a take-home supply of medication, whether that's additional 2 days or that's 3 days. So it sounds like that's what you all are really going to have to try to flesh out in the final wording to see if that can be clarified, so this doesn't sort of bump into, you know, state regulations. Is that correct?
That's correct. That's definitely correct. Making sure the biggest thing when you look at the regulation is making sure that the regulation follows the intent of the law. And if it doesn't, we ask for clarification on why it doesn't. And I think it's really important, like you said, Dr. Ketchum, in all our conversations with Hill staffers, with CBO, with Congressman Ruiz's office, that was the intent. The intent was 3 days worth of supply that you could take home instead of having to come back to the ED every day, which as we said before, was a significant barrier.
Awesome. All right. So there'll be basically more to come on this, because there'll be a time before this actually gets implemented and time for some clarification. And of course, like you said, it could take the full 180 days. So it could be as late as June 9th before this goes into effect. Is that correct?
That's correct.
All right. So in summary, new practice guidelines effectively immediately, when it gets listed in the Federal Register, right? So we're hoping that's any day. Okay. Hopefully after the inauguration day, things happen, maybe by the end of the week, let's hope, right? So as soon as that happens, that effectively eliminates the X-Waiver requirement for physicians. It also removes any patient limitations. So no reason to count at all for hospital-based physicians, such as emergency physicians. And this, however, does not apply to NPs, PAs. So the X-Waiver requirement is still required for your non-physician practitioners. They're still going to have to do what they're currently doing. And of course, for physicians, you know, working in a clinic, if they don't want to, you know, get an X-Waiver, they're going to have to stay within that 30 patient limit. And of course, we have the 3-day rule change, the Easy MAT Act, which once again, we appreciate Dr. Raul Ruiz, Congressman Raul Ruiz from California, who wrote that bill with us and worked with the DC office to get that passed. So, I just want to take this moment. Yeah, go ahead.
So just to sum it up also, so the 3-day rule, which we discussed, I mean, we're still going to pay attention to it, and it's still very relevant for non-physician practitioners, since again, the exemption that was created through the practice guidelines does not impact non-physician practitioners. One question we received, Dr. Ketchum, was about residents, how this impacts residents, the practice guidelines. Now, we are still waiting for HHS clarification on that. That's one of the questions we asked the HHS. We're still waiting for clarification, and that's one of the follow-up items which we'll get to you as soon as we get clarification. But Dr. Ketchum, do you want to give a little insight into what your thoughts are on residents?
Yeah, so I'm so glad you brought that up. And we actually just thought about that just yesterday afternoon. We forgot to incorporate it into a slide, but really good point. So the way I interpret this, and once again, welcome Jeff's interpretation, since he's more of the legal beagle on all this, understand the regulations. But if there is no XWaiver requirement, a resident already has the ability to write for controlled substances. I mean, a resident can prescribe oxycodone, right? A resident can prescribe hydrocodone, et cetera. So, and that does not require using the attending physician's special DEA license, right? So a resident can use their, what's often called an education limited DEA license that they have as a resident at the hospital or university to prescribe. So it is our assumption at this time that residents should also be able immediately, once this gets entered into the federal registry, be able to prescribe buprenorphine. Now, Jeff, as I understand you did send this out to HHS for clarification on residents, correct? But I don't think you've heard back yet.
Yes, yes. I signed it with saying that we assume that they can do it, but please validate our assumption. And we're still waiting to hear back that confirmation.
All right. So let's hope that's the case, right? It would be logical that should be the case, that residents should be able to prescribe buprenorphine right away. And this is really important, right? Because we know this is sometimes difficult for residents, interns who really want to be engaged with treating opioid use disorder. They want to be able to prescribe buprenorphine. And in academic centers, sometimes the big barrier is the fact that the attending they're working under didn't get an X-Waiver. So hopefully this will really allow academic programs to move forward as well. So that's the quick summary. Here are some resources. And of course, I think the slide set, Sam will make available to everybody here.
Yes, we'll make it available to everybody.
And so I'd really just like to open this up to questions now, if I could. And I think I'm going to stop sharing the screen so I can kind of see the chat as it comes up.
So do you want me to read the questions, Dr. Ketchum? I'm happy to.
Oh, okay. Let me see. They're coming up now. All right.
Yes, we have some questions. The first one from Dr. Hine. The HHS guidance precludes a long-term relationship between the ED and the patient. What steps will ACEP take to ensure that patients do not return to the ED as their primary access point for buprenorphine management when they can't find an office-based physician for their care?
So
Dr.
if I can
Ketchum, do you
answer
want
this
to
if
take
I
this
could. Yeah. So first of all, we can't obviously preclude that. And I would still rather a patient return to the emergency department if let's say they were given a 30-day prescription from the emergency department or even a weeks-long prescription. I would still rather that patient return to the emergency department to receive another prescription if that meant that the patient didn't return to using, was not injecting. But we can't guarantee that. But what I would recommend is that as many folks as possible review the educational programming that ACEP has provided about building a successful ED buprenorphine program. And a lot of the things that we talk about in building a successful buprenorphine program is developing those relationships in your community. Most communities do have providers. Obviously, the law can't mandate, that every community suddenly has other providers writing for buprenorphine. But those are relationships we encourage you all to build in your community, and you can build them into your patient navigation system in multiple ways, to help bridge people to treatment. So, and I think that, by the way, I know ACEP just ran an outstanding course on this on Friday and on Saturday. Friday session was really dedicated to building a successful ED buprenorphine program. All those programs, they're all recorded and they're all available. In fact, Sam, do you want to weigh in on that just a bit, if you can add a comment?
Sure, I can. Yeah, so first of all, there was a 2-day workshop. First day was mostly focusing on buprenorphine, prescription to the ED, and second day was more on pain management. If anybody would like access to those recordings or do those slide decks, they're available, open access to anyone and everyone. I'm going to put my email in the chat. Just feel free to email me and I can send you links to those.
All right, that's outstanding. Jeff, you want to take the, I'll just take this next question. So I guess here's the next question. It says, is it clear that physicians do not need to apply for the X-Waiver, but is the 8-hour training still required? So the 8-hour training is not required. Well, once again, as soon as this is entered into the federal registry, I just have to keep throwing out that caveat. We expect this to happen any day. It's a strange time to have this right before the inauguration, et cetera. But as soon as that is entered into the federal registry, emergency physicians do not have to take an 8-hour training class. They do not need to apply for an X-Waiver. They should be able to just prescribe buprenorphine like they would prescribe any other controlled substance. The once again, does not apply to non-physician practitioners. So PAs and NPs, of course, will continue to have to use an X-Waiver to prescribe buprenorphine. We'll still have to go through the process of getting the 24 hours of training and getting a license. Okay. I'll read this, but I'm going to let Jeff respond. But in Tennessee, it says APCs do not have an independent practice, right? If a PA has an X-Waiver, but their supervising physician does not, and they prescribe buprenorphine for opioid use disorder. So first of all, in this case, because the law doesn't change what happens to APCs, right? I would assume that there's no change for them. And if the state law still says that they have to prescribe compliant or pursuant to whatever their supervising physician does. So for example, in New Mexico, a PA can have an X-Waiver and still prescribe buprenorphine even if their supervising physician does not. So I'm going to have to defer to the state of Tennessee to provide additional clarification. Jeff, do you have any additional comments there?
No, I would just say that you're right, that you would have to defer. The state law doesn't preempt federal law. So whatever the state level requirements in Tennessee are, you would have to still abide by them. But again, there shouldn't be any changes in the ability for non-physician practitioners to be able to obtain the X-Waiver. And whatever you're doing in Tennessee now, it wouldn't be, in terms of non-physician practitioners, it wouldn't be changed. But yes, you always have to look at state law. The state law in all these federal regulations, it always defers to state law, and particularly on scope of practice it matters.
All right, I'm going to adjust this next one. It says, why are NPs and NPAs excluded? It says you speak about improving patients' access to care as being the impetus for pushing for this. So I will tell you that as one who worked closely with ACEP and also with multiple partnering organizations, including AAM and American College of Medical Toxicology, ACMT, Pew Charitable Trust, the ONDCP, Office of National Drug Control Policy, multiple folks were at the table trying to push this forward. And so often it's hard to get the complete change you want. And so you sometimes have to accept kind of a stepwise change. So while this isn't the complete answer, and personally, speaking as an addiction specialist and as an emergency physician, I'm hoping that we can get the entire MAT Act, once that gets reintroduced, passed. And the MAT Act was all about completely removing the X-Waiver. It's how it applies to physicians as well as PAs, NPs, et cetera. So I kind of feel like the job is half done, but we should celebrate the success we have so far. But I also will tell you that other organizations, including Pew Charitable Trust, who has been amazing in how well they've organized many of these groups together, will be continue to push forward, as well as others working in the addiction community. Jeff, any other comments on that?
No, I think at this point in time, we are, again, very happy that with these practice guidelines, we're considering other, like I said earlier in the presentation, other legislation and other that was in the previous Congress that would get rid of the X-Waiver requirement. So that's all that's under consideration. At this point in time, we're just really thankful that the HCS did this, issue these practice guidelines. And again, because they have to be continually updated and modified over time, we'll be carefully monitoring them. But right now, we are just looking at some of these questions that you're asking on the webinar today. We're trying to follow up with HCS on. That's our priority right now, is to really focus on making sure that it's properly implemented and that you understand everything you need to do to be able to effectively implement this and prescribe buprenorphine when appropriate.
Yeah, and I think we would all, hope that as data is being monitored, that hopefully we can continue to reduce issues relating to stigma, and that we can get more physicians engaged, particularly if many have cited the existence of the X-Waiver as a barrier. Well, I don't want to take the 8-hour class, et cetera. That we can get more physicians prescribing, and we can show that we are saving lives. That then hopefully that'll add further data in our ability to push forward to remove the limitations on PAs and NPs. So okay, next question. It says, will the requirements for PACE accreditation be updated? Oh, good question. So yes, I would assume that we are going to have to modify the PACE accreditation. We'll have to see what that looks like, but clearly there's no reason to require folks to get an X-Waiver. I can't say for sure What that's going to look like, I'll have to defer to the PACE Board of Governors as they review those requirements. But I would imagine that they'll come up with, I guess a more updated guideline. It's my expectation. Sam, do you have any comments, or Jeff, any other comments about the PACE accreditation? I don't know if there's anything else to add at this point.
So the only thing I'm going to add is the PACE Board of Governors are aware of this update. They're looking at the guidelines. There's going to be an update. We just don't know exactly what the timeline for the update for the criteria will be.
And I think obviously before the PACE Board of Governors does anything, they're also, like all of us, are just waiting each day to see this listed in the Federal Registry. I think Jeff gets like 100 emails a day saying, Jeff, is it in the Federal Registry yet? Isn't this Federal Registry yet? So
Yeah.
Okay, is there another question? We have more. Or is that it? Oh, I see. We can scroll down. Here we go. I now have the ability to scroll down on this. All right.
The next question is, what will it take to remove the mystery surrounding the buprenorphine prescribing? Dr. Ketchum, do you want to take this one?
Let me see that. Say it again.
What will it take to remove the mystery surrounding buprenorphine prescribing?
I see. Yeah. So I think the issue about this is, once again, still related to stigma, right? So I think there's not only a stigma about patients with opioid use disorder, there's a certain stigma about the XWaiver itself. I mean, while that may have been well-intended 20 years ago at the time, given the tremendous amount of stigma and misunderstanding about opioid use disorder and the existence of what's known as the Harrison Act of 1914, right? That's what all this relates to, that it's illegal to prescribe opioids to somebody who has an opioid use disorder. That's why I'd have all these special laws, right? Well, I think this just continued education, such as ACEP's been very engaged with, and partnering like with the AAP, PCSS. And so even though this rule has changed, or hopefully we will see it change very soon and go live in the Federal Registry, I just have to throw that caveat out about, I think, 10 times a day, right? But as soon as that's out there, we can't let up on education, right? We at ACEP, with the pain management addiction medicine section, with all the tremendous educational activities that Sam has organized, we're going to continue to educate on this. We're not going to let up in the least. We're going to try to seize the moment, in fact, while the barrier is down, to pull as many of our colleagues forward. I guess that's all I can add additionally to that. And not only that, within ACEP, right? But this is not just ACEP. I mean, this applies to your hospitalists and other physicians, and seize the moment. I think across the field of addiction medicine, to get more and more folks engaged. And we're really hoping that as the XWaiver goes away, because I think many of us feel that the XWaiver itself, the existence of the XWaiver, contributes, to the stigma of opioid use disorder, that a physician has to go get special training to prescribe this special, highly dangerous and or morally questionable drug or something, right? I mean, you don't have to get an XWaiver to prescribe fentanyl patches or oxycodone, or Dilaudid, right? But you got to get an XWaiver prescribed buprenorphine. So we're hoping that the wall starts to crack, that we really can use this to address the stigma, and then engage more of our colleagues. Okay.
So the next question is for the Easy MAT Act. Do you want to read that question, Dr. Ketchum?
Okay, so with the Easy MAT Act, proposed dosing would be 16 milligrams daily times 3 days. Suspected state regulations will apply. In Ohio, more than 24 milligrams prescribed daily. So I'm curious about the state of Ohio. Is it really that no more than 24 milligrams can be prescribed daily, or is it just that that's all that the insurance will cover? So typically the challenge I deal with in the state of New Mexico is that Medicaid doesn't pay for any more than 24 milligrams per day. So but yeah, that's still what we teach. That's our standard prescriptions out of what we dispense at the hospitals I work in, which is the Presbyterian system in New Mexico. So multiple of our hospitals have buprenorphine programs, and our standard 3-day supply, whether that becomes a 2-day supply, right, if you administer in the ED, or whether you can give them 3 days, even if you administer in the ED, as we sort those, we'll fine tune the wording there. We set up our standard take-home packs of 16 milligrams, but that's not set in the law. That's kind of just our standard practice. By the way, just to totally change the subject slightly here, there used to be in the package insert, for buprenorphine. So whether you're talking about the brand name products, Suboxone or Subutex, there used to be the old package insert talked about only having 12 milligrams on day 1, then 16 milligrams on day 2. And the package insert has been completely changed. So that's really no longer any kind of like even FDA requirement. It's been reworded to state that it's important to get the patient up to a therapeutic dose quickly, so that they don't, return to use. So, I don't know, Jeff, any other comments on that?
No, I think you summed that up. But yes, I mean, I think just deferring to the state on that, and we can try to follow up with you offline if you have any more questions about your specific state. You can try to work with our state folks to try to get some of these questions answered. Again, this is a preliminary discussion. There's some outstanding questions, particularly when you think about state law versus federal law, which is always a tough issue. But we'll get them sorted out. But overall, again, we're just very excited about this change. I know there can be technical details we work out, and more questions I'm sure will come along as you start to implement these changes. And for your emergency physicians and other who don't yet have an XWaiver, again, if you have an XWaiver already, you can either use this exemption or continue having your XWaiver. But I'm sure there will be other questions, and we're here all the time to try to get these questions answered for you.
I want to jump into the next question. Thank you, Jeff. So this is a really nice comment. It says, thank you all, very helpful, exciting for this success for our patients. And just commenting on how much they enjoyed the XWaiver education that ACEP did put together. Thank you for those kind words. I will tell you that that was a great effort of about 12 different emergency physicians, as well as ACEP administration, kind of trying to herd cats. Dr. Kate Hawk and I chaired that, but we had outstanding input from experts across the country. So we are going to be thinking all about this. How do we develop like a 1-hour module or 2 hours that gives you just the nuts and bolts, the most important information you need to have to go live? But can we complement that with a whole lot of short additional modules to cover a variety of advanced additional topics? We're going to be meeting soon, and kind of we want to make sure that we can provide all the education you need for emergency physicians in the ED, but we also want to make sure we can provide the essentials so people can get up and running as soon as possible. So Sam, any other comments on that?
Yeah, the one thing I was going to add is, so most of, if not all of the education related to X-Waivers and the trainings are completely open access and available to anyone and everyone. So they're not behind an ACE payment firewall, because having them remotely has given us a lot of flexibility. So whatever does come up as far as the new modules or new education, we will try to send out information and updates on them to ACEP membership as frequently as possible and through all of our channels communication.
If I could also add this, we have current 4x4 classes scheduled. We have one scheduled for tomorrow, in fact, and we have another 8-hour class EM course that ACEP is running next month. We have 8-hour classes in my organization, Presbyterian in New Mexico, that I'll be teaching for them. So we're not going to stop teaching the XWaiver course. We may teach the full 8-hour course less frequently. We may do the 4x4s less frequently, but we actually have a lot of folks who take our courses who aren't emergency physicians. We have hospitalists, folks from primary care, a variety of specialties who are using our ACEP education, which is great. We're just all about getting education out there everywhere. So there'll be more decisions made on this, but I imagine we'll continue to offer those courses, the existing courses, probably just not as frequently, as there won't be as much demand, for the full 8-hour or for the 4x4 classes is kind of my expectation. But there'll be more to come on this. All right. Is that all the questions? Are there more?
Are there any back questions?
Let's see. This is state regulation. We need research. Okay, great. Let's see. I think that's it. So if anybody else has anything to add, feel free to jump in. I hope that we've been able to address with as much as we know so far. And I'm sure that Jeff will continue to get 100 emails a day for the next few days until something happens with the Federal Registry. As soon as, I can tell you this, as soon as It is posted in the Federal Registry. We will get a notification out throughout ACEP that this has actually gone live. This is fully gone into effect. So we will do that.
And just so that you know, also on these slides in this webinar, if you have colleagues who are unable to attend this webinar, a recording will be available online. We'll send a link out so you can, or you want to go back and listen to something again on the webinar. We'll let you, we'll make the link available, as well as the slides, because there are links in the slides as well. So we're happy to share that as well after the conclusion of this presentation. So thanks so much.
We might even try to incorporate one extra slide about residents, just to put that question in there in advance.
Yeah.
Since we didn't think about it until the last minute when we were writing the talk. So.
Well, thank you everyone so much for joining today, and please feel free to be in contact with us with any further questions. Thank you again.
Thank you all.